So when Dr. Keung, he will become the head of department of research center. So he have to have some network many doctor in our hospital come here. So good afternoon. Today is Dr. Wilkinson. She will be talking about. He will talking about anomaly of the vascular and communication. And this subject I think is a very interesting, but because when we have a good diagnosis and we can find out the good way and quickly for management and treatment for this patient, because those disease is a very severe complication. And please for your talking today.
Good afternoon, everyone. I'm resident of oculoplasty department. Today I want to introduce a presentation about ophthalmology of intracardiovascular abnormalities. My presentation includes two parts. The first is I will introduce some kind of aneurysm, and the second is carotid cavernous fistula. As you know, ocular symptom and signs may be the first sign or presenting sign of many intracardiovascular malformations. So ophthalmologists have to recognize promptly to facilitate appropriate diagnosis and therapy for the patient. So aneurysm is a acquired arterial approaching that locate at the most commonly locate at the branching point of a major artery that coursing through the subchoroid space at the base of the brain. The three main signs of aneurysm, of intracranial aneurysm, is between the junction of posterior communicating artery and internal carotid artery. The second position is junction of the anterior cerebral artery and the anterior communicating artery. And the third is the bifurcation of mid cerebral artery. So about the symptom and sign of aneurysm is often asymptomatic up to 90%. And when they rupture, they create a subchoroidal hemorrhage. And only 10% of the aneurysm have symptoms of mass defect. So the also associated symptom and signs of aneurysm depend mostly on the location and are frequently a neuro-ophthalmic condition. So the first entity I want to introduce is cavernous sinus, carotid cavernous aneurysm. As you can see in the image, there is a aneurysm inside the cavernous that start from internal carotid artery. This condition often present in women than men, and on patients more than 50 years old. The clinical setting is a painful, often legia with complete or partial cranial nerve paralysis of third, fourth, or sixth nerve. Sometimes the patient can have optic neuropathy or visual loss when the aneurysm compress the optic nerve. This is quite rare and in the last phase of the disease. Significant proptosis is also rare, so this is the characteristic feature that can have differentiate this condition from other aneurysm and fistula. About diagnosis, MRI is still the best in non-invasive method, and angiography is a invasive method that can help us differentiate an aneurysm from a neoplasm or have with relationship of aneurysm to the ICA or internal carotid artery. This is the 45 years old woman with a painless diplopia, and on the MRI you can see a aneurysm that have a trend toward erode into the dura. On the angiography you can see the back. Yes, in this picture the aneurysm project into the dura. About the cause, most of the patients have a progression of a combination of third, fourth, or sixth nerve paralysis, but the pain is absent or continuous. 25 patients will resolve spontaneously, and only 4% patients will rupture and can cause a carotid cavernous fistula or subchoroid hemorrhage. Treatment is indicated if visual loss and cranial neuropathy persists, or sometimes persistent ocular pain is also an indication. Treatment of choice is endovascular intervention. The second entity is posterior communicating artery aneurysm, which is quite familiar with ophthalmologists. It often presents with isolated third nerve paralysis, and it is the most common cause of isolated third nerve paralysis, and sometimes it can cause subchoroidal hemorrhage or visual loss. When a patient has isolated pupillary sparing third nerve paralysis, we need to evaluate for other causes like microvascular disease, like diabetes or hypertension. Neuroimaging is still similar, MRI and angiography. Therapy include surgery or embolization. About the outcome and prognosis, the third nerve function gradually recover over months, and if the patient has a persistent diplopia, we can use alternate patching for visual rehabilitation or creams or occlusion therapy. And if after 3 or 6 months with no recovery, we can consider strabismus surgery. But if the patient has recovered a little bit, in the 6 months, there is no need for a surgery. Ptosis surgery is performed once the diplopia is controlled after strabismus surgery, and the dilation of the pupil and pupil ciliary muscle is common, even if in the patient who recover extraocular movement. The next entity is carotid ophthalmic aneurysm. Here is the picture demonstrates anatomy of cavernous sinus and other relevant structure. And a carotid ophthalmic aneurysm is a outpouching that can compress the visual chiasm or optic nerve. The carotid ophthalmic aneurysm can have up to 20% of cases have bilateral aneurysm, and 30 to 60% of cases has a aneurysm elsewhere in the brain. And woman is clearly more often affected than man. The age of onset is from 40 to 70. The clinical presentation, the most common is subchoroid hemorrhage. Although the proximity to optic nerve or optic chiasm, many patients have no visual disturbance. Interestingly, patients who experience visual loss have a lower incidence of subchoroid hemorrhage. So it is a patient we present in our hospital. She is a 40 years old woman with a history of headache about 2 months. She was diagnosed with internal carotid artery aneurysm and was having a stent placed endovascularly. After that, she developed visual loss in the left eye with visual acuity in the left eye is no light perception. Right eye is 20/30. After that, she was diagnosed, developed another aneurysm in front of stent position. This aneurysm compressed chiasm. Here you can see the aneurysm of the patient. Sometimes visual loss caused by aneurysm is insidious, and we can misdiagnose as other entities. This is the 75 years old woman complained about poor vision in the left eye with VA is 20 to 200 hours, and after that he was done cataract surgery, and the VA improved to 20/30. After 4th month, after cataract surgery, there are a slight increase in the CD ratio in the left eye. 11 months after fundus photography, we can see a bearing sign of a blind spot in the left eye, and IOP is 20/20. So she was suspected for having normal tension glaucoma. 10 months later, the patient returned caused progressive visual loss, and on perimetry we can see the left eye visual field has lost almost in the entire nasal field. So after that, the patient was done to MRI and angiography, and you can see a aneurysm with partial thrombosis, and it compressed the third ventricle sinus, and it is the angiography. The patient refused surgery or intervention, so after 3 years he lost her vision. So you can see the carotid ophthalmic artery aneurysm can be misdiagnosed as a low tension or normal tension glaucoma. And only 40% of patients have visual loss. We also have a IPD because frequent involvement of visual chiasm and both optic nerve. The diagnosis depend on MRI angiography. Treatment is surgery and embolization, but the prognosis of this condition is quite poor. The last aneurysm I want to introduce is anterior communicating artery, and clinical presentation is often a subchoroidal hemorrhage. After that, the patient can present a syndrome called Thurston syndrome. It is a syndrome when a anterior communicating artery aneurysm rupture, and it associated with intraocular hemorrhage. The possible mechanism is when the patient has subchoroidal hemorrhage. it increases intracranial pressure and cause retinal venous stasis. And after that, the patient has intraocular hemorrhage. The VA is often reduced to hand motion or light perception and remain poor until resolution of hemorrhage, often within 6 to 12 months. Because the resolution conservative therapy is often recommended, and vitrectomy only considered when there is no improvement of vision. The last entity I want to introduce is carotid cavernous fistula, which is an acquired direction from ICA to the cavernous sinus, and often the etiology of carotid cavernous fistula is from trauma, and often is a motor vehicle accident. About the classification of CCF, there is two types of classification. The first is viral classification, which is classified into 4 types. The A type is the most common type, and it is the direct connection between the ICA and the cavernous sinus, and the 3 left type is a indirect connection between ICA and cavernous sinus. It is a picture. You can see in type A, there is a connection between ICA and cavernous sinus, and in 3 left type, there is an indirect of meningeal artery into the cavernous sinus. So the type A is usually a high flow type, and often are post-traumatic. And the type BCD is often less severe symptoms. Clinical presentation is very typical. The classic triad is enophthalmos, conjunctival chemosis, and subjective fluid. Other symptoms is vision blur, diplopia, headache, ocular pain, and maybe visual loss. This is the table that lists the most neuro-ophthalmic sign of traumatic carotid cavernous fistula. You can see the IOP is the high IOP is very common. After that is third for sleep nerve paralysis, chemosis, ptosis, bruise, and sometimes it's venous retinopathy. This is some picture of CCF in Vietnamese patient. You can see chemosis with involvement, ptosis, corneal lesion, and sixth nerve paralysis. Diagnosis is from MRI, but DSA is still a gold standard because it identifies CCF location, arterial supply, flow rate, and venous drainage to have classify CCF and have to plan for treatment. Here is the example of traumatic CCF. A teenage boy fell off, and he had immediate left CCF. You can see chemosis of the conjunctiva. It is a picture of ophthalmoscopy. You can see venous retinopathy with a lot of hemorrhage and dilated vein. The patient after that had angiography, and you can see have a fistula between ICA and the cavernous sinus. So about the treatment of CCF, type A, which is a high flow in direct CCF, usually require urgent treatment with endovascular intervention. But if the patient has diabetes, CD, which is an indirect connection, in conservative management is reasonable because the patient will resolve spontaneously in 20 to 50% of cases. Other conditions like glaucoma and ischemic retinopathy may require medical treatment or photocoagulation. About prognosis, CCF prognosis after intervention is quite very good with successful closer enough to 93 to 92%, and direct and indirect CCF carry a favorable visual prognosis unless there is evidence of retinal or optic nerve ischemia prior to treatment. Thank you for listening.
Thank you very much for your presentation today. And I think the subject is very interesting. And our doctor here also, there's some doctor who are very interested about this subject. And have any question or comment for Dr. Sir? Before I have one student about, I think more than 10 years old, about 15 years old. There's one doctor, now he's vice head of ophthalmics department in my hospital. He does the thesis that I'm certified supervised for him. And he's does the fistula, cavernous fistula, and use a coil or blocking the cavernous fistula. And he do it in my hospital, and also for the results very good after his use a coil to block the cavernous fistula. And I know Dr. Kuhn, he also have a thesis about this subject. You have any question or comment?
Yeah, thank you, Professor Sergeant, for the introduction. I did the thesis, it's called well concerning the CCF, that's a long time ago when I was research master degree. And at that time, until now, it would be the same. 70 90% of CCF, direct CCF, I mean direct cavernous between it well concerning with traumatology history. As you know, at that time there are many cases of accident, transportation, circulation, and many patients went to our hospital because many lesions with surface ocular at the front of the eye, also, and patient have a bruise here, many bruise at the head, his head at night. At that time, there are many misdiagnostic wrong. They diagnose this with something like a conjunctivitis, episcleritis, something like that. And after my thesis, many doctors now put a well diagnostic between the CCF direct other disease as in our ophthalmology. And your topics, Dr. Senator, today talk mentioned the vascular abnormality, intraoperative, the big chapter in the neuro-ophthalmology, I think. And we may forward stenosis, and so you that mentioned about other reason, fistula, but the other kind of pleasant abnormality. We would talk something about stenosis of ICA, for example, intracarotid artery. Many cases, stenosis that contribute a lot of patient in neuroanatomy also. Dr. Sen, that's I would say with that. At that time, I sent many patients CCF to Bạch Hospital because where they have DSA, that means digital or suppression angiography, DSA. And many patients our hospital with high success result because at that time they have a quite very good method to deal with that. It's quite 95% the patient have a good result. Before that, they have a balloon to do the surgery, but fell rate many high. So nowadays they could not talk anymore about balloon, clip, something. And the other good method to deal with that, we have glue, acrylic glue. It pumped directly into the fistula and they can close the fistula very good. And it is interesting case that the person that saying that in some case we have a wrong diagnostic with glaucoma. I think a big lesson people, young doctor here can learn about that. The CCF indirect, you should do well. The diagnostic, well, difference of diagnostic between CCF indirect or CCF well diagnostic with glaucoma, that means the on ocular side very insidious, many things so silent, but actually they have CCF indirect, not glaucoma, and you should do well the fundus of eye examination to make the difference in diagnostic between CCF indirect with glaucoma. So I think that's all. Thank you, guys.
Thank you, Dr.
Okay, thank you very much. There's any question or comment or Dr. Chu share? Yeah, Professor Bob.
Thank you, Dr. Sen, for your presentations. In fact, as Dr. Keung had said, the topic is very large, and in 20 or 30 minutes, it's quite difficult for you to talk all about that. And I just wonder a thing not relating to the content of the presentation, but about your role as a speaker. So you're a resident, and I know that you are very active, and I see you very often in this state to talk in the role of the speaker. So what is the reason for that? So you like to speak, or some other don't want to speak, so to give you the duty to speak instead of them? And like today, you speak in the role of whom? You are on behalf of resident group, or of ophthalmology department, or any other department?
I think it is all of that reason you mentioned. This topic is very hard for me. Dr. Kwai said that you can do that, you just do that, and you send me some paper about this topic, and I just read and present it for the people of the hospital. And I can say that I love to speak in
You have to be speaker, right?